to this morning session on Bailout IOL options from basic to advanced. It's a video course. This is a situation all cataract surgeons face in their practice sometime or the other. It may be a large pseudorient or severe zonular dehiscence. Secondary IOL is, it bails us out of this situation. A know-how of how to get out of the situation will give tremendous confidence to the surgeons. It can be antechamber lens, or it can be skill fixated IOL or iris claw lens. So for this, we have eminent faculty, Dr. Arup Chakrabarti, who is an ace surgeon, and he is the director of Chakrabarti Eye Care Center, Trivandrum, Kerala. He will be talking to us on AIOL revisited, and then the tips on iris claw implantation will be given by Dr. Deepak Megur, another prolific surgeon. He's cataract, he's a glaucoma consultant from Bidar, Karnataka. And then iris claw IOL implantation in special situations will be given by none other than AS Cornell surgeon, Dr. Srish Kumar from Coimbatore, Tamil Nadu. And then skill fixation with dumbbell technique by one of the best VR surgeons I have seen, Dr. Professor Guru Prasad from Joshi Institute, Karnataka, Hubli. And then intrascleral fixation, IOL fixation with advanced techniques by Dr. Srinivas M. Joshi, a young dynamic surgeon from Joshi Institute. He is a VR surgeon. And then with the expanded PTFE sutures, I'll be dealing with it. So now we'll start the session. Over to you, Dr. Arup sir, please.
Good morning, friends, and thanks Satya for asking me to participate in this course. Actually, the course is titled as AIOL Revisited. So for me, I have really believed in the efficiency of AIOLs if properly selected, proper circumstances. So for me, it is not exactly revisited, but I'm going to highlight some of the points which have to be kept in the mind when you use this lens, or some of the situations where you should not be using this lens. Now, sometime back we edited a book on posterior capsular dent, and there was a chapter, big chapter on AIOL by Dr. Biro from Hungary. So if you want to see all the detailed analysis, meta-analysis, and the various comparison, this thing, you can go through this particular book. So now there are certain prerequisites for AIOL implantation. Many surgeons actually who talk against this particular lens, I have seen their own cases, and either directly or over the conferences. It is basically the cataract surgery complication which has not been managed well, and now the blame has been shifted to AIOL. So we need to know what are the prerequisites, and only in if these conditions are satisfied, AIOL lens should be used, and they'll give good results. So patient should anatomically have a normal anterior chamber angle. If peripheral anti-synechic is present, it should be present in less than 2 clock hours in either meridian. The anterior chamber depth has to be normal. Good standard normal iris architecture is one of the prerequisites. Good corneal endothelial health. There has to be patent and generous peripheral iridectomy once you implant the AIOL. Usually prefer to use these lenses in patients who are of this senior age, elderly patients, senior age group. And you must understand the intraocular lens, AIOL lens design, and know how to handle it properly. So the selection of, there are certain selection criteria. Say, for example, what should be the power of the AIOL lens and what should be the sizing. Now, as regards power, when you calculate the IOL power during your whatever optical biometry that you do, you can use the A constant for the AIOL. In case it is a certain decision and you have not really calculated the AIOL, there is one rule of thumb. It was published in the Survey of Ophthalmology in 2005. You reduce 3 diopter from the calculated in the back PCL power. But I would suggest that you use the A constant in your lens calculation formula. Choosing the correct size is very important. So whenever we do optical biometry, you always get the horizontal white-to-white diameter. And we need to use a lens which is 1 millimeter more than the horizontal white-to-white corneal diameter. So this is a must. So now the standard AIOL lenses which we have in the inventory are to 12.5 millimeters. So if you're dealing with a very small cornea or a large eye, in that case you need to ask the company to provide you with additional inventory in case you have PC rent and you have no other options, and this is the backup lens, which if not used can always be returned to the company. So there are hazards with an oversized ACIL, and I'll be showing you some of the pictures, anti-segment images, ovalization of the pupil during surgery. So that time itself we'll know that it is an oversized AC lens and it has to be taken out. And in the long run, ocular discomfort and angle erosion can always happen. Undersized ACIL, there will be excessive mobility, and if you have not expanded it, there will be endothelial compromise. The UG kind of syndrome, cystoid macular edema may be more common. So this is about the AC handle. When you take out the AC lens from the box, as you pick it up with the McPherson forceps, the AC lenses are vaulted anteriorly. So the right side should face the cornea because that is where the vaulting is, and so basically you want the lens to be vaulted anteriorly. And many people actually they flip it, they're thinking that the lens has to be vaulted away from the corneal endothelium, and then it is since it is vaulted posteriorly, it is tightly attached to the iris, or if there's antivitreous phase, and postoperatively you can always get secondary glaucoma and all sorts of complications. So this is the common thing. You must inspect the lens. And then this is a very old technique. I have not used an ACIL for quite some time. So this is actually, I had a complication here, superior phaco, so I went for the temporal approach, made a scleral tunnel, and then the IOL was properly sized, and the lenses should always be kept horizontally. So that is, in case the lens is slightly undersized, so the propeller effect will be much less if you have kept the lens in the horizontal meridian. Some people say that the AC lens should not be dialed. I think it is not so, because the lens is not resting on the angle. It is resting on the ciliary, but it is on the scleral spar. So if you have placed the lens properly, the gentle handle rotation after compress the haptic, make sure that the haptic which is in a position of the angle is pulled away from it, and then rotate the nucleus and keep it in the right axis. Now these are some of the problems that an improperly selected ACIL can give rise to. So recently there was a discussion in the WhatsApp group, and then some senior surgeon commented that he misses the Pannu lens. Pannu lens was a very versatile lens. It could be kept in the anterior chamber, it could be kept in the posterior chamber. But these three-piece design lenses should, no lenses meant for the posterior chamber should be kept in the anterior chamber. Now, so this is actually some of the oversized intraocular lenses. You can see how much, I'm not getting the, yeah. You can see how close the haptic is from the optic margin in all these cases. Okay, so this is a particular case where the patient had the haptic coming in the section, and so I just actually wanted to rotate the lens, but then I realized that the haptic was very densely adherent to the scleral tunnel. It was an SIS done elsewhere. And now, of course, I don't see many complications because surgical skills with SICS has grown tremendously. People are doing extremely well. So I could not really mobilize the lens. So here, initially I didn't want to extend the incision, because if you extend the incision, there is always a fistula. So you have to, closing this thing will be quite difficult. So when I went, put the lens behind into the anterior chamber, and made a temporal tunnel, scleral tunnel, and then explanted the lens. Then I realized that there is adequate support for a PC lens. When I did posterior synucleolysis and iris retraction, then injecting visco behind the iris, so there's adequate posterior capsule. So I used a posterior chamber lens in the ciliary sulcus, as you see here. So many a time, when you have a PC lens, you get panicky and you just put an AC lens, or you take a knee-jerk reaction and do things which should not be done. So it is not a crime to keep the patient aphakic. You should have a prior discussion with the patient and say that there may be a rare situation where, in the best interest of your eventual outcome, I'll leave you aphakic, and once the eye heals a little bit, I most probably will be able to do a better job than if I put a AC lens straight away. So this was again, there are these are the post-operative pictures. The patient had done quite well. So this is again an oversized lens. So I expanded the oversized lens and used a proper lens, properly sized lens. So basically the guidelines should be followed. You have to be aware of some of the surgical guidelines which I have discussed here. And adequate anterior vitrectomy, anter-segment reconstruction is mandatory. And it has to be lenses to properly sized, and I've given you the guidelines. These multiplex lenses are very good, they can be compressed. So, it is not like all one size fits all. So, if you have a 12.5 millimeter ACL in the inventory, I think it should do well. And so these are good. So now I have reviewed many of the meta-analyses and of the different types of secondary IOLs in complex situations. And most of the conclusions used to be that it all depends upon the surgeon. There is no definite superiority of one technique over the other. So this was recently, just recently published in JCRS. It is a review and a meta-analysis, which showed, actually it started out with 1356 articles, and then it could review only 15 articles. And the conclusions I'm just showing you up, say, overall complication rate included, which was non-significantly lower in the iris fixation category. So there is some justification of using iris fixation lens in complex situations. Transient corneal edema, which is the most common complication in AC placement, and complications like vitreous hemorrhage, eye disintegration, dislocation are more commonly seen in scleral fixated intraocular lenses. Cystoid macular edema was meaningful higher after various eye fixation methods. So conclusions, risks associated with particular techniques should be taken into account in preoperative counseling and planning postoperative treatment. So with all these precautions, I think in selected cases, ACIL still gives us good results. Thank you very much for your attention.
Thank you, sir. By the time Dr. Deepak gets ready, an excellent talk on ACIOLs. In fact, I have seen many ACIOLs, well-done ACIOLs still doing very well. What is your opinion? Still you think, there's a role for ACIOLs now also? And because it's easier and probably like, maybe, yes.
See, if it is a very challenging phaco situation, before I get a PC rent, I would have anticipated problems. So I would convert it into scleral tunnel and do an SICS and put a PC lens. Okay. But AC lens, as I told you, I have not used for last maybe 3 or 4 years. There are certain situations where I have used in the past are very uncooperative patient. When we had a PC rent and you cannot take the patient back to the operating table for the second surgery because AC lens is much faster. So, only I think that is the main indication where you still may end up using an AC lens. Otherwise, I would not prefer to use an AC lens. But if you're using, then you have to follow the proper technique.
Sir, one question, yes, sir. The different sized ACLs, sir, are they available still now, or how do we order?
See, my inventory has, I get it from Aurolab, 12.5, and in case I require, so inventory is always there, I pay for it, for 12.5. But if it is high-sized or low-sized AC lens, for example, earlier they used to have the inventory, but now they don't have. So, for example, if it is, earlier they used to have 12, 12.5, and 13.
Okay.
So you have to order, then, so they make it specifically.
So they'll make it specifically.
Yeah.
Ready stock that might
Yeah,
not be available.
yeah.
Okay.
But as I told you, I keep this as a standby in
Yes,
case something, because I cannot say that because I didn't have the lens, so I'm keeping a fake.
Yes, yes, yes.
If I'm keeping the FA kick, it is planned.
Yes, sir.
That's why I'm keeping the patient FA kick.
Thank you, sir.
Now, the biggest problem with ACIOLs is not the ACIOL. It is the problem with the surgeon who has mismanaged the phacoemulsification, done a very, very, what should I say, rough phaco, and or corneal endothelium is already gone. I have seen many such surgeons, the post-op patients, when I was at Aravind, and subsequently I see the videos when AC lens have been implanted. So it is, I don't think you can attribute the blame to ACIL. It has to be, the surgery plus the ACIL. But you're right, if the ACL count is less than 1500, I'll be a little reluctant to use an AC lens. In that case, I'd go for a scleral fixation. That is a good point. But see, for example, maybe so these surgeons are biased on the podium against AC lenses because they have had a lot of problems in their own hands. On the other hand, when I was at Aravind, I have taken a lot of scleral fixated, the iris claw lenses, Daljit Singh, more than 50 or 60. So maybe I'm not biased against these lenses that it is associated. All those patients had corneal edema. So I would prefer to use AC lens, but I know that iris claw lenses, Deepak also will show, and Satya also shows, they do extremely well.
Dilated pupil pupil sometimes we don't constrict, or the pupil doesn't constrict with intracameral myotics, we sometimes find that after the lens implantation, next post-operatively the pupil will come down and there will be some iris tucking, iris root tucking.
Yeah.
So is there a way to manage that complication?
No, I'll be using, intracameral pilocarpine that is routinely stocked in my this thing. So if it doesn't really come down, I use the Sensky hook to stroke the iris. It comes to about 4 or 5 millimeters. So once I know that haptics, it is resting on the scleral spar, and I'm rotating and there's no deformity of the pupil, I leave it assured. But you're right. But if in spite of all that, if I see the pupil is peaked, then I know that it is an oversized intraocular lens or there is an iris tuck that has happened.
I think the most common reason for blame of the ACIOL is the surgeons would not do a proper anti-vitrectomy. So it is, as sir was telling, it is lack of doing the proper vitreous management at that stage, and then we end up with the complication and then blame it on the AC lens.
Correct.
If you done a perfectly done anti-vitrectomy, and all lenses would work equally well.
You're right. AC lens is a very good excuse
because
for the
automated
surgeon.
anti-vitrectomy concept was not there 10-15 years back, and they never used to identify vitreous and just push the lens and blame it on the lens rather than the other things.
right.
Vitreous management was the most the most common reason why the corneas used to go blank or uveitis or all those things.
No, just to cover up one's mistakes, blame it on AC. Yes, right. So now we'll move on to the next topic. I request Dr. Deepak Megur to speak on tips on iris line IOL implantation.
Thank you, sir. Thank you for this opportunity. It's a pleasure. Is the color is something different here? Okay, so maybe I'm seeing from a different angle. Okay, fine. No, the angle of view, it looks very different here from here. Okay. So these are some typical cases where you would not have the bag to place a posterior chamber lens, since these are situations which are indicated. This is a phacolytic glaucoma. You can see the amount of zonular weakness which we are having, and we do an intracapsular extraction, and these are situations where the iris claw lens would be my preferred choice of late. And in this case, I'm doing this before doing an anti-vitrectomy because anti-hyaloid phase was still intact. So you align the lens properly here, and I'm holding the lens with this forceps. This is called as a Clayman forceps. The reason I prefer this is slightly, it is thinner, so you don't lose the chamber when you introduce it. One trick what I'd like to suggest is, where do I hold the lens? Because this notch which is there in the haptic disappears as this is negotiated behind the iris. So if I hold the lens exactly at the area where this notch is, it would give me an idea like where the notch would be, so that my tucking of the iris would be a little bit easier. So this is where, this is one of the things which I practice. So holding it that level, and then I prefer to use a blunt instrument like a 26 gauge cannula rather than your hydrodissection cannula. So now it is being negotiated under the iris, and instead of using the dialer, okay, this is what, because many times you see the iris perforates, you have a stromal hole there. So this is how it is, and immediately you get a tuck or a puckering of the iris which suggests that you're impaired. One again tip would be just to move the lens a little bit so that you can be sure that the iris is also moving. This ensures that the enclavation is proper and you don't drop the lens. So I would not leave the lens until this sign is confirmed. Then again the chamber is refilled with OVD and the hands are switched, and the same thing. Let me pause here again and show you that, just a second, let me go back for this frame. So look at the incision which is created here. So this is a longer incision, this is not right, okay? This is the longer incision and this is not right. The incision has to be something like this, very small, just like a stab incision, because the moment you have a longer incision, the moment I introduce my instrument inside to tuck, you have lot of corneal folds, and the reach is not towards the mid-periphery rather than toward more centrally. So, planning your incisions appropriately is one of the things. And if you have an engagement of the iris which is more than what is required, invariably you have something like a cat's eye pupil. And although it might look good on the table, next day you'll be surprised that the pupil will be stretched towards the area where it is. And I prefer to do an iridectomy with the cutter itself. These are the settings: IA cut mode, irrigation, aspiration, and then cut. And maybe just one single cut is good enough to do an iridectomy. And in this case, now in the later stage, I'm doing the anti-vitrectomy, and also I'm going to remove the OVD which is behind it. So again, to reiterate the point that, if you don't do a proper anti-vitrectomy, and if the vitreous is there around the vicinity of the pupil or the lens, every lens is going to create problems. Okay, so it's mandatory to check and reconfirm that there is no evidence of vitreous around. This is another case of a microspirophakia case, and these are the cases where you would consider something like. And again, I just like to share it here. How do you remove the lens? Rather than using any vectis or dialer, I think in these cases we don't want to put any stress on the highlight, because once you use a vectis, you are going to risk of always catching hold of the antivitreous phase, and that is going to cause a traction. So just inject viscoelastic, viscoexpression. This is the safest way to do an intracapsular extraction in such eyes. And at this stage, you'll still be sure that the antihyaloid phase is intact, and you would not rupture the antivitreous phase. And again, I would prefer, if opportunity is there, to place the lens before doing an vitrectomy, simply because when the eye becomes soft, when you've done a vitrectomy, it's very difficult to maneuver the lens, and the visibility is compromised because we get a lot of corneal folds, because we don't have a fluid going inside like how it would be when a vitreous surgeon is operating. So there's a lot of folds, but again, the forceps this is the forceps which I prefer to use, and hold it exactly at where it has been shown. And this is probably one important tip which ensures that you don't struggle to find where the notch is. The OVD of choice here would be sodium hyaluronate for me, simply because it maintains the space much better rather than just using HPMC. And this is a blunt instrument, 26G cannula. And I learned this trick from Dr. M.S. Ravindra, because I picked up this trick from him. He uses this 26G cannula, and you can see the small pucker appearing. People are worried that the lens can drop down, but if you are sure that the enclavation is done right, confirm it by moving the lens, and the iris has to move along with it, then you can be rest assured that the lens is unlikely to drop. So again, you are going to refill the chamber if need arises, and then switch the hands and do the similar tucking on the other side. So don't leave the lens unless until you really are sure that the first enclavation is done right. And this lens, it has to be pushed against the iris. It has to be pushed against the iris. Then the tucking is much more easier and effortless. So try to, I would prefer to enclave in the mid-peripheral region rather in the most peripheral part is not accessible, and the lens is not so big as well. So mid-peripheral region is where we would like to tuck. And if you are not happy with one tuck, maybe two tuck, and you can see this nice pucker coming up. So now you are sure that the lens is not going to drop down. You can see there is a slight horizontal ovalization of the pupil. And in certain situations, when the vitrectomy has already been done, I would prefer to go through the main incision, both the irrigation and the aspiration, to remove the OVD. Because now to introduce these through the side ports and to get under the lens, it might be a little bit tricky. So I think this would be my last case here. Again, you're going to fill the chamber with OVD. This is sodium hyaluronate. This is maybe a diluted pilocarpine which I'm injecting inside. Let me just fast forward it. Okay, this is a incision which was made earlier. It was not planned. So here again I'm redoing the incision, posterior limbal, a very short stab incision. This gives us better. We can always stain it with the trypan blue so that we don't hunt for the location of the incision when you're trying to do it. This will help us to negotiate it much better. So again, this is another type of iris claw lens forceps, where it has a plate on the posterior arm. Again, but the holding would, again, I would prefer to have this. But this is slightly bulkier than the one which I described earlier, the Clayman forceps. But nevertheless, this also does the job, and we can do it. The forceps which we use might be very small for it to thin. I think with this, I'll stop my presentation because all the points are covered. Thank you so much for the opportunity, sir.
Yeah.
Sir.
Thank you, Dr. Deepak Meru.
Sir. Uh, Sir, the causes of inflammation are many. You know, there could be some retained lens matter or whatever it is. And even sometimes the iris incarceration in the wound, that itself can incite inflammation. So that itself is a risk factor. But you may have to use steroids for a longer duration of time. Regarding the dilatation of the pupil or irregularity of the pupil, it may not be round, because that again, you know, the amount of iris which is tucked in, that would determine how much of the pupil is going to dilate in that area. So that is a little bit uncontrolled, I should say, like, you know, you really cannot predict. But if you've done many, then you get in the control, like, you know, you feel how much of an iris is gotten, and maybe you can, you will not have such an horizontal dilatation of the pupil.
Thank you, sir.
No, not sir. Yeah, but sometimes, you know, what happens if the surface of the forceps is not smooth or ragged or something, it might cause. Definitely, it might cause. So, but in my hands, it is not hand. But that's a good point to be considering.
Now I request Dr. Shrish Kumar to speak on iris IOL implantation in special situations.
Thank you, Dr. Satyamurthy, for the opportunity. And my talk is a continuation of Deepak's talk. It was nice videos, Deepak. So nicely have demonstrated the procedure. So it makes easy for me to continue with my talk. Any indication for iris clip IOL is a special situation, and any compromised capsular support or any complicated surgery with the compromised capsular support is an indication for iris claw lens implantation. And I'm just going to show a few videos. This is actually a regular case of iris clip IOL. It's an aphakic eye, and I'm just creating a two side port paracentesis exactly 180 degrees away from each other, and I'm just swiping with the iris spatula to see whether there is any tags of vitreous in the pupillary area, and then placing the iris clip lens. This is the holding forceps which I use. This is actually a broad-based forceps, which is slightly different from what Deepak had shown. So this IOL stabilizing forceps, and I usually hold it at the junction of haptic and optic, not exactly in the center, which Deepak had shown. It gives a good grip, and I use a Sinski hook. Of course, I don't pull it, and then so this is a picture, the post-operative picture. This is what you want to have. This is a pinch. There is a dimple on the iris. This suggests there is adequate enclavation that has happened. This is another special situation where you can see it. I was actually planning to do a phacoemulsification with the capsular hooks, and then CTR I thought of implanting. So I was making some side port incisions for introducing my capsular hook. But surprisingly, like I didn't realize that it is such a advanced zonular dehiscence. After injecting fluid into the anterior chamber, I realized that there's hardly any support. You can see there is tilting of the lens. the tilting of the lens, and if you see the sorry. So the support is only here. This is 1 clock hour of support here, and there are another 2 clock hours. So it is actually tilting. This axis is the fulcrum, and the lens is tilting. So there is hardly any support. It's a hard cataract. Then I thought of proceeding with the ICC. I removed the lens in toto and enlarged the incision. I made a sclerocorneal incision, tunnel incision in the same site. So hardly 3 clock hours of support, 1 clock hour in one axis and the 2 clock hours in the other end. So then the routine procedure of iris clip IOL implantation is done. And the procedure is quick. It hardly takes 10 minutes for us to complete this procedure. It's not like scleral fixated IOL. In our hands, it takes at least 20 minutes. This is another situation where it's an aphakic bullous keratopathy. It's a chronic case of aphakic bullous keratopathy. You can see the opacification of the cornea also and the thickened epithelium, and you do anterior vitrectomy, and you need some support for the tamponading effect of the air bubble when you are introducing a lenticule into the anterior chamber. So for that, the iris clip IOL implantation definitely helps. It gives us support from behind, and the air won't escape into the vitreous cavity. So this is one special situation wherein we can do a iris clip IOL implantation. I just want to show that what happens if you are injecting air into a aphakic eye without any support. So it won't stay in the antechamber. So it's like it escapes into the vitreous cavity, and even through the side, the iridectomy site also it is going into the vitreous cavity. So it's a difficult situation. Either you should have a SFIOL. SFIOL, usually there will be a gap between the pupillary margin and the lens. So iris clip IOL works very well in these cases. It's very difficult to maintain a tamponading effect. So invariably you end up having a dislocation of the lenticule which you have implanted. So it's another case. Here there is a large sector iridectomy iris defect which is extending from 2 o'clock position to 10 o'clock position, 10 to 2 o'clock position, and I'm just suturing the pupillary margin. This is a McCannell's kind of procedure which I am doing, and so you have a pupil kind of shape in the pupillary area, and then you can introduce your lens, and of course it's a little difficult. Sometimes you may break the suture which you have placed, but it actually helps. And the iridotomy which you have here is of course covered under the iris, so the patient will not have much symptoms. This is how it is post-operatively. This is another case of traumatic cataract where I was not sure about the status of the posterior capsule. Anterior capsule is broken because I could see the cortex in the antechamber. And like any other traumatic cataract with the anterior capsular rupture, went ahead and did the cataract extraction. This is actually a very soft cataract. It doesn't require any phacoemulsification. It's just a phacoaspiration and irrigation and aspiration. But to my surprise, there is a tear in the posterior capsule also, and it's a large tear in the posterior capsule, anterior capsule is already gone. Only I have some tags here, the capsular tags here and here. I could have gone ahead and placed a lens in this axis, but it is risky. I am not sure about the support here inferiorly and superiorly. So in such cases, iris clip IOL comes in handy, and just takes another additional 5 minutes for the lens to be placed. This is another case of complicated cataract situation where the surgeon was doing a phacoemulsification. It's a small pupil, and there is a zonular dialysis and anterior and posterior capsular rupture. So this is a situation wherein there is no point in preserving this capsule. You can do anterior vitrectomy and go ahead with the iris clip IOL. And there is a dislocated bag with the IOL. It's a severe PXF case. Again, you have to, it's difficult to reposition this. This is actually 5.25 millimeter phaco profile lens, which PMMA lens, which we used to implant many years, like 2 decades back. Now, of course, I don't think this kind of lenses are available. It's actually a phaco profile lens. Which has overall length of around 12 millimeters. So you have to just explant this and place a iris clip IOL. Here again a case of complicated cataract, and there is hardly any PC support in this particular area. There is support here. I thought we can place a lens PC IOL, but there is no support here at all. While retracting the pupil, I could see a ECR, that's endocapsular ring, CTR. You can just wheel it out and remove the capsular remnants and place iris clip lens. So I have 1 minute. So this is another case. The surgeon has operated thinking that the lens is in place, but next morning when he saw it is actually decentered. So there is hardly any capsular support. You need to remove this and either place iris clip lens or do SFIOL implantation. This is again a case of subluxation. The patient had injury. It's a case of iris clip IOL in situ, but in one area it is slightly decentered. It was holding on to the pigments on the back side of the iris in one particular area, and this needs re-enclavation, and there is vitreous pushing the lens inferiorly. Inferior, that's nasal, towards nasally, and you need to do a vitrectomy and then re-enclave it. This is the last case. This is again a case of iris clip IOL implantation, but the lens was hanging. It was attached to the iris in one side, but the other side there is no enclavation. You have to just go behind this mark, that is where the iris clip is pinching the iris, and then you bring it to the pupillary plane and tuck it. So it's you have to be very careful. You can just fish it out in the open vitreous, but you have to go just below the iris where it is enclaved, and then you can bring it to the pupillary plane and reposition it. So any complicated cataract surgery with compromised capsule is a special situation, and the iris claw lens comes in handy in these situations. Thank you very much. Actually, it is as we actually compared it with our vitreoretinal colleagues do SFIOL and anti-segment surgeons, we do iris clip IOL implantation. It's almost the same. There is hardly any difference as far as the CME incidence and the recurrent UATs and all is concerned. It's a compromised situation, complicated surgery. The overall outcome may be less compared to the regular cases, but as such, there is hardly any difference between SFIOL and iris clip IOL implantation in our cases.
Thank you.
The meta-analysis that I referred to in this year's last
Yeah.
had a high incidence of CMA with
Iris clip, okay. Maybe. Yeah, no, it works very well in our hands. Most of the cases we do, anti-segment surgeons prefer this in our setup.
No.
The idea of going behind the inclination on one side when the other side has got dislocated.
Yeah.
It's a very good idea.
Yes, yeah.
Doing Parthena going and
Yeah, it's just to go behind there is a dimple mark, just go behind it and you just pull it. Yes, yes. Usually after vitrectomy only we do this, yeah. Yeah, total vitrectomy, yeah.
Now, one question to both Dr. Srish and Deepak. Your experience in pediatric age group, iris because iris is very hyperreactive in pediatric.
Yeah. Again, of course, the inflammation part, it's much more aggressive in case of pediatric age group. But we have not seen any unusual complications in a pediatric age group. In a case it is mainly a traumatic cataract and progressive subluxated cases, we try to preserve the capsule and try to place a PCIOL, but it's only the traumatic cataract where there is no support for anterior and posterior capsular support is not there. Such cases only we try this iris clip IOL implantation. Not found anything different from adult cases.
Dr. Deepak?
Yeah, I have got limited experience. I got two patients, one with microspirophakia and other with Marfan's. The age would be somewhere around between 12 years, one patient, and another 14 years. Follow-up is around 4 years until now. So far, so good, sir. Not any major issue. But until now.
Only problem is that iris atrophy and later on the iris
is,
lens can get dislocated.
That's a possibility. But as for the inflammation, my experience is very limited. So I can talk only about these 3 or 4 eyes, that's all.
Yes, thank you, Dr. Srish Kumar. It was an excellent demonstration of iris clip implantation in special situations. Now I request Dr. Guru Prasad to speak to us on dumbbell technique, scale fixated IOL. Over to you, sir.
Dr. Deepak, you said so far so good, but then they are at a very young age. We don't know what will happen when they become adults and maybe 40, 50. So I think at that time we should be mentally prepared, or at least counsel the patient's parents that they might need another surgery. I think that's important. Okay. Thank you, APAO, and thank you, Dr. Satyamurthy, for involving me in this very nice symposium on IOLs. I'll be sharing my technique, which I've been doing for the last 4 years, and I found it to be extremely simple, extremely predictable, and without complications. आगे नहीं चल रहा है. Yeah. So the common indications of a secondary IOL, I think I will not go into these details because I think everyone knows, and part of it has already been covered in the previous talks. So the most important message that I want to give here is that any unplanned aphakia, as in a large PC rent occurring due to any of the multiple causes during cataract surgery, that holds good for all secondary IOLs, even the iris claw lens, and in case of Marfan syndrome. These are the two indications, incidentally, which are my major indications for the dumbbell technique, which I'm going to talk about. And these are the prerequisites for before you plan the implantation. I think I'll not go into these details again. So the first, among the numerous techniques that we have in our armamentarium today, I am going to speak on 4 flange technique, also called the dumbbell technique. using 6-0 prolene. I think dumbbell technique which Sergio Canabrava actually innovated was with the 5-0, but I found that 5-0 doesn't give me as good predictable results and as good centration as 6-0 does, and therefore I'm using 6-0 with a rigid IOL. So this is the schematic of the Sergio Canabrava technique, the Brazilian surgeon, and this is the surgical video of what I do, making conjunctival incisions at 3 and 9 o'clock positions in an aphakic eye which has been left aphakic in a camp patient, and opening the tunnel, reopening the tunnel, the previous tunnel, which is just about a month, which is fresh and just about a month old. And these are the cauterization steps which we have to do very minimally to keep the sclera tough. The tunnel has to be reopened, and I put in an infusion in most of my patients. I'm a VR surgeon and I'm not scared of the pars plana. I put in an infusion and just use it now and then to restore the IOP when the eye becomes soft. And this is the Hoffman's pouch that I'm creating on both sides. This is the left side Hoffman's pouch, which I use to cover the flange on the left, and the similar one on the right. This is the right eye, and that is the Hoffman's pouch on the right hand side. This has to be very superficial because the flap has to be thin, but the bed has to be thick because the flange has to be held well. I opened the incision now, and I am doing anti-vitrectomy both outside the eye and inside the eye now. The pupil has to be clear, and there should not be any strand of vitreous left behind, although you can resume the vitrectomy once the lens has been placed. This is the 6-0 suture I was talking about, which I place through the 30 gauge needle, and not all 30 gauge needles are of good quality. We have to be wary of that and get this suture out. It's a 4 centimeter suture, simple suture without needles, and that is the suture coming out from the wound. And similarly on the other side, I diametrically opposite point, I use the incision to be passed, the needle to be passed, and get the suture out from the other side. And when the two sutures are out and the two ends of the scleral side are also out, I cauterize the scleral side of the suture just to ensure that it doesn't slip back into the vitreous cavity. That is the other end being sutured, and this I'm using a Bowie cautery, which is just a simple device which is available commercially nowadays very freely, and which runs on battery. This is the lens, the standard rigid lens I was talking about, which I use. I put in the other end, the scleral incision wound and the SICS wound end of the suture, and that I also cauterize and make it as flange. And I take care to see that the flange is on the lower surface of the iris when I implant it, lower surface of the IOL, not rubbing against the iris. So that's very important to do, because otherwise the flange can rub against the iris and cause chronic cyclitis. So this is the other end of the suture through the other eyelet of the SFIOL, and I guide both of them at the same time, pulling the suture out so that the lens does not sink to the bottom and there is no need to pull it out again. This is the laser which I am using this time. Just to show you this, I am using doing it just to show you that laser also can be done to create the flange and not the cautery all the time. The cautery is of course good. Sometimes if the battery is weak, it may not work. If you have a laser in a full-fledged VR setup, we always set up the vitrectomy machine for other cases, and that is always available in our center. So that is the flanging that we do with the laser. Now the suture is, the wound is closed. I opened the infusion now and then just to restore the IOP I was telling you. And this is the tightening of the suture. I like to keep it little tight so that we have an astigmatism which can be controlled over time. So at the end of 2 months, I decide whether to cut the suture or leave it like that, depending on what astigmatism the patient ends up with. And this is the final result. So this is the dumbbell technique. But I'm going to show you one more technique since I have time of 8 minutes. A technique where I have used the dumbbell technique which I use for dislocated IOLs, totally dislocated into the vitreous cavity. What happens is usually after 9 to 10 years of scleral fixation done with the 90 prolene, there is a biodegradation that happens, and that causes dislocation of the IOL, either one side or both sides, and the lens is seen in the vitreous cavity. Patient comes with sudden loss of vision. So this is the similar technique that I'm going to do for the dislocated IOL, except that I do it in a closed manner. Closed eye refixation, as I call it, is this technique where I thread the suture through the eyelet in the vitreous cavity using chandelier illumination. And since I have a good VR setup in my institute, I'm able to do this. And this also I have done about 8 cases so far, and they're all doing very well. Similar technique here, I'm using 26 gauge needles. I don't know for what reason. I think it was probably because the 30 gauge needles were not of good quality at that point of time. The other, I'm sorry about the glare, but you could see the shadow there, and similar threading of the eyelet was done, and this is the flanging. So basically the technique is the same, except that it is done intravitreally using laser to flange it, and that is the end of the surgery. So the most important thing is to prevent a slack. You have to pull the thread which is out of the 3 and 9 o'clock positions. Sclerotomy is very hard, so that you don't have any slack inside the eye, and then cut about 4 millimeters of, leave just about 4 millimeters of suture and cauterize that point. That is good enough to cause, to create a good flange for you to prevent slipping into the vitreous cavity. I think with that I conclude. Thank you very much.
Thank you, sir. That was a nice demonstration. One question until Dr. Srinivas gets ready. What is the longest follow-up that you have with this particular technique?
4 years since I started this. My longest follow-up is 4 years, and these patients are really doing extremely well. They somehow, all the other complications which we used to have with the 9-0 suturing method are not there with the 6-0. I'm unable to explain why they don't have these complications. It's good to have no complications, but the reason why I am not able to explain it is probably because of the short suture, and maybe the scleral bite is not there. Maybe the panelists can also contribute to why there is no reaction. So it's a reactionless post-operative course.
Yeah. Do you feel 6-0, proline, it lasts for a longer period than 9-0?
Of course, it does. I mean, that is what I imagine. 9-0 definitely biodegrades in about 10 to 12 years. I've seen all my patients coming back now with dislocated either one side or others or both sides. Dislocated IOLs, and I have had to redo with using this technique now, using 6-0. I tell them that I've got better sutures now, and I'm doing this for you this time. So that is the scenario. Being thicker, I think it should be less biodegradable. It may last for 20 years, if not more. That's what I imagine. But let us see what others have to say.
And what should be the size of flange on either side of the?
On one side, on the IOL side, it should be big enough to not to pass out or slip through the eyelet. That we check it before implanting. And on the scleral side, it need not be very. I am not very strict about the size, because over time the sclerotomy, the passage through the sclera would heal and also get integrated with the flange. I think that's okay to hold the lens. Yeah.
Thank you, sir. Any other questions?
It's not as good as 30 gauge. 30 gauge is always better because opening is larger, so the flange has to be bigger. And one more thing, glue. I forgot to tell you that glue is better in all these SFIOLs where you make multiple scleral openings, because it sort of makes it watertight rather than just leaving it to the healing process, which is sometimes delayed and patients have post-operative hypotony. I think we should have glue, and glue really makes it firm the next day. Next day you will find the eye very firm and without any hypotony.
Thank you, sir. That was an excellent demonstration. Now I request Dr. Srinivas Joshi to speak on intrascleral fixation of the various techniques.
Thank you, sir. At the outset, I would like to thank AIOS and Dr. K.V. Satyamurthy, sir, for including me in his instruction course. So I'll be just playing a few. Oh, cannot play media. Sorry. Okay. So here a few of these intrascleral fixation videos. I'll just show you a few of them. So here this is again the old video where you are just making a marking, you are just using the flaps and dialing out the same IOL. I think this was done by Dr. KVS some long time ago, and then removing that CTR. Since it was a 3-piece lens, you can use a 23 gauge or a 25 gauge instrument, externalize it, and then make a small intrascleral pocket and tuck it inside the pocket. Using a 26 gauge needle, just make a small scleral tunnel and then tuck it on both the sides. So this is what can be done by without having the trocars or infusion line. Now coming to the next video is the Yamane's technique. Again, you see here, this was a dislocated IOL where frag was done in this case, and after doing the frag, now I am using this 30 gauge thin bore needles as was being discussed previously. So these are always better because of the diameter is less, the wound entry size will be less. So I am just trying to do a railroading technique, trying to push the haptic into the lumen of this 30 gauge needle and then use this Bowie cautery, and similarly do it on the other side. Is always challenging to do it on the trailing haptic. Some people suggested to bring it out and then do it, otherwise if it's possible do it, you can do it, but make sure that you don't break the haptic, and then just try to flange it on both the sides and then tuck it back into the sclera. Now this is another case, again as Dr. Guru Prasad sir showed the dumbbell technique. Here I am preloading it into the 30 gauge needle, and then since there is a trap wound there, I didn't want to disturb that. Taken a temporal tunnel which was made, and then slowly bring out one haptic, and then similar way bring out take inside the other haptic as well, and then bring out both the haptics out, the 6-O-Prolene outside, and then thread it into the eyelet of these SFIOL. Then flange it on both the ends and then just pull it. Just always make sure that you pull and check, otherwise inside in the vitreous cavity it might fall down. So just pull both the ends and then cut it and then just flange it. Now coming to the next set is, this is one of the video which I wanted to show you, that 1 week post SFIOL, this was a threaded SFIOL done by my colleague. So what we did was, this is another way, I am just trying to show it to you. Instead of again explanting and doing everything, just pull and see. If this SFIOL is moving, that means the thread is still connected, and then take a small stay suture, the anchoring suture you can say, and then once you make the anchoring knot, now you cut that main SFIOL knot, then now you pull it back. Now you can see the other side of the haptic is now, the lens is now centered, and then tied to that anchoring knot which you had taken earlier. So in this, you can see in just 14 minutes this whole procedure was finished, instead of again explanting, redoing and repeating the same steps again and again. Now next is, as Dr. Guruprasad sir also showed, these are the few of the videos I want to show. A single haptic dislocation that is called as the dangling SF-IOL. This was a traumatic case. So again 30 gauge thin bore needles were used, and since the 6-O-proline was already threaded in that suture, I just took the other end of it and passed it inside in the vitreous cavity and threaded it into the eyelet of the SF-IOL which was dangling inside in the vitreous cavity, and then slowly hold the haptic of it and then bring out that end of the suture. Then just flange it, make sure that the bulb is good enough, and then check it. It's always better to check it internally once you go inside, and then slowly remove these 30 gauge needle, cut it, flange it. Now coming to the next set of this is again very recently done, again single haptic dislocation. So after doing a vitrectomy, we can see the remnant of the so here I am using a chandelier and just made a one port entry. Cut that remnant on the IOL, whichever is there. Otherwise, what happens is this sutures, since we are doing the dumbbell technique here, this might irritate the ciliary body and cause chronic iritis cyclitis. So here again I am using already a threaded 6-O-proline, and then slowly thread it inside, and then take the other end of it and externalize it. And once we externalize this, again you need to flange, make sure that the bulb is good enough and flat, then go inside into the vitreous cavity. Can always cross check, double check it, bring out the other end, and then just flange it. Now this is another my last case where again decentered 3-piece IOL. Here I didn't want it to explant it, again a traumatic dislocation. So both the ends were almost in the vitreous, but while sleeping down it used to come up, so I thought I will refix it. Same again, use the marker, and here I am using a 27 gauge. This is since I didn't get a 30 gauge this thing, because I want to bring it out, the haptics, externalizing of the haptic technique. So I use a 27 gauge condemned forceps, not very good because these are the basically ILM forceps. So just bring it out with a 27 gauge root. That's the smallest this thing. If you don't have a 30 gauge instruments, since we don't have it. Similarly, make again a Z track on the other side. Again use this ILM also in a similar fashion, then catch hold of the haptic, slowly externalize it, and then flange it, and then push it back into the scleral tuck. This is the post-op, the previous corneal scar because of the trauma, and the patient is doing really well. So thank you very much for the patient listening. Thank you, Dr. KVS sir, for this allowing me.
That was a nice collection of videos and an excellent presentation. Thank you very much, Dr. Srinivas Joshi. Now, just one question. I have seen a lot of cases where the flange is exposed on the conjunctival surface. Is it okay if we can leave it like that, or
No,
should we cover?
It depends upon how bad is that the flange. If it's a flat, then it usually doesn't erode the conjunctiva. But if it's a triangular or a sharp peaked, then it always keeps rugging, it might come out. So what I suggest is the Bowie heat cauteries, they are always best because they heat it and you get a good bulb like configuration. Earlier we even used that, what is that instrument which we heat it? Heat cautery.
Heat cautery.
The
Ball cautery.
ballpoint cautery. But that causes a flat like this thing, configuration. Even lasers also, if you use it distinctly, it might turn good. Otherwise, if you have any of the doubts, always make a flap. And these all procedures can be done under the flap, and the flap can be closed. You have done such in some few cases. Yeah. And since you make a Z track, usually these goes back. Once you push it, small flange, it
My
usually.
second case, you saw, I didn't make a flap. I made a groove. In a big
Hoffman's
groove.
pocket.
No, Hoffman's pocket
Not-
was the first case which I showed.
Achha.
A groove, just a groove, and it is
That
a
also
big
can.
groove, not a perpendicular groove. And then it goes into the groove, and that itself covers the flange. I think that is a very good option, and for lazy people like me, that is the best.
Best. Thank you.
We have not been talking about the Gore-Tex switches. You know, that has sorted out a lot of problems.
So that is
So
his,
next talk is on Gore-Tex.
he's the Gore-Tex man, so I didn't touch it.
No, one more thing. I have seen you doing a lot of these CMT flex lenses. You find them good? I mean,
Yeah.
you also
Sorry, I
conducting
would
a
like
study?
to beg to differ with the anterior segment surgeon sitting here who uses more of iris claw lenses. Rather, it is almost a similar, since you place it over the iris and handle the iris. It is just a very simple technique where you make flaps on both the sides. It has a good T-shaped. Fortunately, I didn't get it right now. Otherwise, I would have shown that video also. Just externalize it. It sits very good. The only problem with the CMT flexes are they are hydrophilic, and sometimes it might break. But over the time, the company just spoke to them. They said that they have improved on the quality of the CMT flexes also. Luckily, till date, I have done almost around 20-30 CMT flexes. None of them have broken. But if you don't hold it properly, that is the very key point here. If you don't hold the exact T, then it will break. Yeah. Yeah. But these are pretty much stable, sir. If you don't, rather than doing iris claw, I am telling it as a supplementary to the iris claw.
How long it will get exposed?
The erosion of sclera. My concern is it is very thick. Erosion of sclera over a period of time. Like, that is what my concern basically. It is relatively much more thicker than the flange which you create.
Correct. Correct. But these are the fixation points, these are more stable than the flange. The tilt, the decentrations and all those things, using the sheen plug images also, we are doing around 100 cases now. We are comparing between all the three techniques, the flange technique, the suture technique and the CMT flex technique. Hopefully in the next meeting I will be able to tell you.
I think the CMT flex is the best, most
Stable.
stable. Because it has got a wider point of
Yeah.
and the anchoring is also much better.
Correct.
Perfect T there.
Correct.
There is no question of stability.
I think ultimately the patient wants vision. So if you ask me, CMT flex of all the three techniques or lenses that you mentioned, CMT flex gives the least vision to the patient. I don't know the reason. It is a hydrophilic lens. It is prone for deposits. It is prone for developing haze. Prone for developing haze. In my own experience, me and Apurva together have done about 60-70 cases by now. And we have found that it is not so good. So we are now slowly, guardedly doing CMT flex and going back to the other lenses.
Yeah, fine. Thank you. No, but this is a flat thing. No, I don't see why it should erode sclera. And under the flap, yeah.
It is so bulky, it may not, but then it is quite, when you look at it for the first time, it is quite, what should I say?
Thick, it's a little bit thicker. Yeah, that's right.
It is the most stable probably.
Yeah.
It anchors it very well. There is no question.
Yeah. No, No, I'll just go on to the topic straight away. See, the drawback with poly. This is the last topic, so I think we are on time. Till 9:30 we have, yes. Right. No, till my this thing gets ready, any questions regarding the previous topics? No, wait. Yeah.
Ruled out retinal problem, we have ruled out high astigmatism, which is basically and in spite of all that, it's purely attributable to the lens, I'm sure. Whether it is due to haziness, due to hydrophilic nature of the lens, causing some fluid imbibition which is not seen clinically on slit lamp, or whether it's due to some other reasons, I'm yet unable to decipher. I want to explant one lens and see, in a case where vision is very poor, I want to explant a lens and send it for analysis.
Sir, ठीक है. No, one thing, Dr. Deepak and Dr. Shrishma, any tips on disinclination? Though we say it's easy, you can disincline, but it's not that easy. You have any disinclination of the thing?
Disinclination is definitely difficult as compared to inclination, but it can be done. Like you can hold the lens in the optic, and with the side port you can make a slightly bigger side port and go ahead with the iris forceps, that is toothed forceps, and just pull the this thing what knuckle of iris forward, so that disenclaves. And at the same time, the opposite movement. With the main incision, you are going ahead and catching the lens. You go a little down and then pull the
Move
iris.
nahi ho raha hai.
So that like you can disenclave the clip.
Video chal raha hai. Next ho raha hai. Okay, fine. Thank you. Now we'll go to the next topic. This is the last topic of the session. We all know that we have seen Prolin sutures 10-0 being used, but the problem with polypropylene sutures is that we call it as semi-permanent because it undergoes biodegradation over a period of 5 to maybe 6 or 7 years. The degradation occurs, and then there is dislocation or decentration of the IOL. So that way it is not a permanent thing. Yes, sir. So best thing would be to use this expanded PTFE, that is a poly tetrafluoroethylene, which is nothing but Teflon suture, which is supposed to be permanent and lasts for a longer period. And then it is microporous, made of Now it is used as an off-label product, being used in GI surgeries as well as vascular surgeons are using it. So now I'll just go through a few videos just to show how we can use this in ophthalmology. So this is the Gore-Tex suture with a atraumatic needle, and then so opposite, just diagonally opposite points on the cornea you mark, and then the suture is passed onto the eyelets of the, or the haptics of the AIOS lens, which has got 4 haptics. And now this is about 4 millimeters on either side, about 1.75 millimeters from the surgical limbus, 4 millimeters, that is the length of the haptics. The distance between the haptics is that much, is made using a 23 gauge trocar, and now the suture is externalized using the forceps. And since it is done with AC maintainer, so we can always monitor we need not use the viscoelastic here. And now the suture is tied on either side. The titration is before finalizing the tie, so the titration is just on either side, so that IOL is well centered. And now under the conjunctiva, the nut is going to be there, but it doesn't erode as we see in other cases. So this is closed like this. This is another situation where, I mean, using the PMMA skill fixated IOL, where the eyelet is thicker. So on either side of the eyelet, using the 4-point fixation. So we can use this. And then using the same technique, the lens is implanted, and then the suture is tied. We can also use a Hoffman's bucket in case if you want to bury the knot, so that can also be used, which I don't have a video on that. And I mean, this is, though surgery looks little unpleasant, but the end result is quite good, and then it is highly inert. So now, this the needle which is commercially available is a Sui needle basically. This is 7.5 centimeters, that is 75 millimeters, which has been shortened to 16 millimeters by instrument company. And now the tip is tapered so that can go through the 26 gauge needle. So this is the modification that I have made. And then, so this is the technique where you, using the same 26 gauge needle, you pass the Gore-Tex suture, which has been passed through the eyelet of the needle under the conjunctiva, again go through, and then 4 millimeters apart, again you enter the with the railroad technique, which we are all familiar with, and again under the conjunctiva, you just go. So this way we have created one mesh. So that will be under the conjunctiva, because so another mesh is created just exactly perpendicular to that, and so this is what we call as you can say artificial bag. This is not my technique, but I mean using Gore-Tex suture is my technique, but with 10-0-Prolene this has been used earlier. So now you have created a mesh, and you can use the mesh for implanting the lens. The regular 3-piece IOL is placed in the sulcus, and then the optic is captured. So it basically there are 2 meshes, one above, one below. So the optic is going to sit exactly in the interface, whereas the haptics are in the sulcus. So this is using artificial. So what next? We can also use the same thing for toric coils and multifocal IOLs, and so that's it. So thank you for your patient listening.
microscope.
Is the 4 millimeter, sir. So photopic pupil. No, I understand. I know what you're coming at. I mean, see, it's photopic pupil. Probably when it dilates a little bit, the suture is exposed. But so far, patients have not complained about the glare and other things. Is that what?
Very beautiful, Professor Murthy. You had only heard about it. And I had also seen some videos of vitreoretinal surgeons using it for prevention of oil coming into the anterior chamber from behind. I think this is a very novel technique, and here it is for the trapeze artist in a circus not to fall down. There's a basket there, there's a mesh there. I think it's similar to that, and really very nice. Congratulations. Yeah.
Thank you, sir.
You know, I mean, there is a thing called Masket basket. Samuel Masket, he had used a tenopropylene suture like to create a mesh for him to implant a scleral fixated lens, and then he removes the mesh later on. So he says that with this strategy, the AC, because post-vitrectomy eyes, it is very easy for him to stabilize the lens when the manipulations are happening. It is called Masket basket. So
Masket, yes, sir. Yes, that's what. Instead of Prolin, I've used this thing, Gotex suture. But I don't know. As I said, probably in the long run, if patient may complain of glare and things like that. Yeah.
Nice technique, Dr. Satyamurthy, that the mesh which you have created is a novel technique. I think you have published it.
No, not yet.
So, and the first video which you have shown is on acryos.
Yeah, acryos
attaching
lens, yes.
the acryos that holds 4 holes and then fixing it to the sclera. But is it possible with the dual haptic lenses, hydrophilic lenses?
Should be. This is also a hydrophilic only. Acryos lens,
Acryos,
probably
yeah,
hydrophilic.
acryos, it works well, but any other lenses which you can use?
No, there's only one Indian company which used to make lenses earlier, the Care Group. Now they have stopped. I have forgotten the name of that. I don't know. Sir, are you aware of any other lenses being used?
No. See, if you are opening up the section, like that, so you can use a standard scleral fixated IOL, with a loop in the haptics.
Exactly.
We
That's
do
it.
routinely such cases where when a rigid lens has to be expanded, and then what we do is remove one needle and do all the looping like intraocularly, and then pass the residual needle from the 2 sclerotomy ports on each side. So pass the needle through the sclerotomy port, and when you tie the knot automatically goes inside the sclerotomy port. It is buried under the sclerotomy. So there is absolutely fantastic results post-operatively. There is no chance of erosion. Very well centered intraocular lens. So then instead of Prolin, now we switched over to Gotex, and this is the manipulation. The 4 sclerotomies, they make it very elegant,
Yes.
very fast also.
Correct, sir. Yes. Yeah, with this, we have come to the end of this session. Anything else that you want to add? So I thank all my speakers and instructors. Still we have, how much time? Yeah, that's right. Another 7 minutes, maybe we can make use of this for, one photograph with all of you, please.